Yes.
Okay, then start the session. Hello.
Hello.
Biplav, are you there?
Yeah.
You can start.
Just
Good evening, everybody, and a warm welcome to our Clinical Oncology Online Course 2021, organized by AROI West Bengal Chapter. And today we are going to present our Module 3, and that will cover musculoskeletal and pediatric tumors. Today our first topic is malignant bone tumors, and that will be presented by Dr. Sayan Das. Dr. Sayan Das, are you there?
Yes, I am. Hello.
Yes, Dr. Sayan Das.
Yeah, am I audible?
Yes, yes.
Yeah, thank you. Monisipa, are you there?
Yes, yes, I'm there.
Yeah, because I'll be requiring your help. You need to scroll my slides, please.
Very much. Is it visible now?
Yes, it is visible.
Okay.
Okay. So, hi, good evening to you all. Today's topic for discussion is malignant bone tumors. By the way, I'm Dr. Sayan Das, a radiation oncologist working in Narayana Health, Kolkata. So, Monitha, let's move on to the next slide. Because, see, I've been allotted 40 minutes and I've been asked to discuss about malignant bone tumors, which is a pretty vast topic. So, what I am intending to do is, I'll be trying to give you an overview of how to approach bone tumors and how to manage bone tumors. Before I begin, during my training days, it was often a question about what to read and when to read. So one of my seniors had given me this a simple formula kind of a thing that as a JR1, you need to read radiation physics, biology, clinically relevant anatomies, and staging of these various tumors and how to work up the various cases. As a JR2, we need to know what is the standard of care. So whether you need to do surgery, you need to give radiotherapy, give chemotherapy, the radiotherapy doses, your portals, chemotherapy doses, all these things. And as a JR3, you need to know why it is the standard of care. So the various evidences, the important landmark trials and all these. Now, as the invitation mail specifically mentioned that this course is for JR1s and 2s, so my talk would be kind of a mostly for the beginners and freshers. So I'll be focusing on the staging, workups, and the standard of care. So I won't be talking about trials, no in-depth discussion because the time doesn't permit. So let's move on. Next slide, please. Okay, so before we begin, so a few words about the epidemiology of malignant bone tumors. First and foremost, they are very, very, very uncommon. They are not your head and neck tumors or breast tumors or your lung cancers or your GI, which you come across quite often. If you see the number is around around 1% of all the malignancies that you see. Even then, it is a significant cause of morbidity and mortality, especially in the younger population. If you see in children, primary malignant bone tumors are the sixth most common, comprising around 6% of cases, Whereas in adolescents and in young adults, they are the third most frequent, just after lymphomas and leukemias. And under the age of 20 years, the three most common bone tumors are osteosarcomas, which comprise of more than 50% of these bone tumors. Ewing sarcoma comprises of another third, and around just less than 10% comprises of chondrosarcomas. Next slide, please. So osteogenic sarcomas, these are the most common primary malignant bone tumors. I think you must have read in your UG courses as well that they have a bimodal peak of incidence. One is around the adolescence with a smaller peak in the elderly age group. And just like all pediatric tumors, or at least which is true for primary malignant bone tumors as well, that they have a slight male preponderance. The most common sites are the metaphyses of long bones. This is important. I'll come to it later on. So the most common sites are your distal femur, your proximal tibia, proximal humerus. In adults, osteosarcomas are considered as most often as secondary neoplasms. So secondary to a sarcomatous transformation of some Page's disease of bone, some bone infarcts, or for secondary sarcomas in irradiated bones, like these. In adults, they most commonly occur in axial locations, which have been previously received a radiotherapy, or there are underlying bone abnormalities. Next slide, please. So what are the risk factors for osteosarcomas? As I said, prior irradiation or chemotherapy. Remember, osteosarcoma is the most frequent second primary cancer occurring during the first 20 years following radiotherapy for a solid tumor in the childhood. The average time it takes to develop these radiotherapy-induced sarcomas is around 15 to 16 years. Even prior exposure to chemotherapy, especially alkylating agents, can also predispose to developing osteosarcoma. Few benign bone lesions can have sarcomatous transformations like Page's disease or fibrous dysplasia. Cell cycle regulators such as P53 and the RB genes have been implicated. So there are a few inherited conditions like Lymph-Romania and hereditary retinoblastoma. And rapid bone growth. This is a hypothesis. This kind of says OGS occurs in areas of rapid bone growth, because if you see the peak incidence is during adolescence. The most growing part of the bone is the metaphysis. It's there where OGS occurs. And OGS occurs at an earlier age in girls. And we all know that girls have an earlier age of onset of adolescence. So all these kind of point towards that with this rapid growth of bone, so probably these tumors arise from an aberration of the normal process of bone growth. And when these rapidly proliferating cells, so they're probably susceptible to oncogenic agents or mitotic errors, which ultimately leads to a neoplasia. Next slide, please. Come to the second most common tumor, which is the Ewing sarcoma. Peak incidence is around 10 to 15 years of age. Again, they have a slight male predominance. Ewing sarcoma is actually a family of tumors. So a group of tumors which have a similar histologic and immunohistochemical characteristics, and they share a typical chromosomal translocations, so that, which means they have a similar molecular pathogenesis, which probably gives us an idea that they derive from a common cell of origin. Hence, these tumors are together clubbed as the Ewing's family of tumors, which includes Ewing sarcoma of the bone or an extraskeletal Ewing sarcoma. It can be a primitive neuroectodermal tumor. It can be peripheral neuroepithelioma. Askins tumor is Ewing sarcoma of the chest wall, and you have an atypical Ewing sarcoma. Now, if you look at the neural differentiation, you will see that Ewing sarcomas have the least neural differentiation, whereas PNETs and the peripheral neuroepitheliomas have the most neural differentiation, whereas atypical ES lies somewhere in between. Now, there are two theories or hypotheses regarding the cell of origin. The most popular one is the neural crest hypothesis, which suggests that there is a neuroectodermal origin, while some say there can be a mesenchymal stem cell origin as well. These tumors are most commonly seen in the pelvis and the other parts of the axial skeleton and femur. Next slide, please. So this is, in today's era, this has gained a lot of importance because this helps in diagnosis as well. Because, as I said, Ewing sarcoma has this common molecular pathogenesis. In OGS, in contrast, there are no characteristics molecular abnormalities. But in Ewing sarcoma, in a large chunk of cases, close to 90% of cases, have this typical chromosomal translocation involving T1122. So what happens is that this EWSR1 gene on the 11 number chromosome fuses with the FLY1 gene present in chromosome number 22, and this novel fusion gene, so that product of that gene is specific for this tumor. And this can be detected using FISH technique. So in cases where this nowadays it's kind of a common technique to confirm whether it is actually Ewing's or not by checking for this translocation. Even in other cases, similar translocations are also seen in other forms of Ewing sarcoma, which includes EWS, ERG fusions as well. Next slide, please. If you go through your textbooks, there's a huge table with several types of bone tumors. I'm just giving you a brief overview of how to classify bone tumors. They're usually classified according to their cytologic features and the matrix that they produce. Say, for example, osteogenic. So the bone-forming tumors are the osteosarcomas, your osteoblastomas, your osteomas. The cartilage-forming ones are like the chondrosarcomas and the chondromas, the chondromyxoid fibromas. Then you have fibrogenic tumors like fibrosarcomas. Then you have Ewing sarcoma and the undifferentiated high-grade pleomorphic sarcoma of the bone. Next slide, please. I think we are all aware of the parts of a long bone. So the shaft is the diaphysis. The rounded ends where the articular cartilage is attached is called the epiphysis. And the region in between the diaphysis and the epiphysis, where the growth plate is there, is called the metaphysis. Now, some tumors have typical locations. As I already said, osteosarcomas and chondrosarcomas, they usually arise from the metaphysis, whereas diaphysis is the location usually for the round cell tumors, like your Ewing sarcomas, your lymphomas, and myelomas, whereas chondroblastoma typically arises in the epiphysis. Next slide. So how do they present? The typical presentation is a pain or a painful swelling. The pain is usually mild at first, maybe aggravated by exercise or trivial trauma. It is often worse at night. Patients usually give you a history of trauma, as that's the event that draws attention to that particular mass. The mass may or may not be present. If and when it is present, it's usually attached to the bone and usually tender. When the mass involves the spine or the sacrum, it can cause radiculopathies or even symptoms of Scott compression. Constitutional symptoms are at times present in Ewing sarcoma, like fever, weight loss, and anemia. Next slide. So if you find a bone tumor, what do you do? So the goals of our staging workup is we need to confirm the diagnosis. The next point is you need to evaluate the disease extent, because I'll come to it later on as well, is one of the most important prognostic factors for these bone tumors is presence or absence of metastasis. So whenever you're finding a bone tumor, you need to confirm your diagnosis, evaluate the disease extent, and you have to assess the feasibility of resection, because limb sparing surgery has now become much popular. So before you decide, you need to have these things in mind. So what do? We ask for these routine blood tests. ESR and LDH are usually raised in say, OJS or Ewing sarcoma. Radiology, I'll come to it later on. A primary biopsy, again, I'll come to it later on in the coming slides. Previously, some clinicians used to recommend doing a bone marrow biopsy for Ewing sarcoma patients because around 10% of patients do have bone marrow metastasis at presentation. But that was true in the pre-PET CT era. Nowadays, with the use of PET CTs for staging workup, PET CTs tend to have a very high negative predictive value. So if you don't have any suspicious focal marrow uptake, you need not do a bone marrow biopsy. Molecular pathology and genetics, as I said, is very important at times to confirm the diagnosis. Next slide, please. So often the first imaging that one asks for in a suspicious bone tumor is an X-ray. And trust me, even in this day and age of your MRIs and PET CTs and all those newer imagings, X-ray is still very, very important to diagnose bone tumors. I'll keep on repeating these words that bone tumors are rare tumors, but they're very challenging tumors. It is not at all easy diagnosing and treating bone tumors. You need experts or you need people who are specialized in treating bone tumors or seeing bone tumors regularly before they can come to definite conclusions regarding diagnosis. So X-rays even now are very important. So typical features, again, X-rays of bone tumors itself is a vast topic. So because of shortage of time, I'll just mention some important, brief, but valid and important points. So for osteosarcoma, the typical findings that we see are the Codman's triangle. If you look at this picture, the white arrows, you see, so when a growth lifts the periosteum up, there is this triangular form there. This is known as the Codman's triangle. The soft tissue is often ossified in a radial fashion, which gives the typical sunburst sign. And you find areas of flocculent mineralization. This term is important, flocculent, because chondrosarcomas tend to have a different pattern called arc and rings. So OGS tend to have this flocculent mineralization, which is suggestive of woven bone production. Next slide. Ewing sarcoma, on the other hand, has this typical moth-eaten pattern. So the cortex at the site of the lesion is permeated by the tumor, which extends into the soft tissues. So they tend to have very poorly defined margins. The other typical appearance is the onion peel appearance, again marked by this white arrow here. I don't know how clear it is for you. So onion peel appearance occurs because of this layers of reactive bone that is formed because of the periosteal reaction. Ewing sarcoma can often be difficult to diagnose because it resembles subacute osteomyelitis, both in imaging as well as in clinical presentations. Next slide. The third most common tumor was the chondrosarcomas. They tend to have a variable appearance, but most of the times the X-ray features are typical of chondrosarcomas, where we find this typical Regan arc pattern of calcifications. And in the long bones, the central chondrosarcomas tend to produce a fusiform expansion of the metaphysis or diaphysis. Next slide, please. So what next? CT scans may be asked for, but MRI is the imaging modality of choice. So if you find a bone tumor, the patient comes to you with an X-ray, you ask for an MRI. Why? Because there is excellent soft tissue contrast. The relationship neurovascular structures, very, very important. If you look at the diagram below, you see the tumor is kind of completely encircling the neurovascular structures. This is an important finding to decide regarding further management. The other important usefulness of MRIs is the intramedullary extent and skip lesions. Again, look at the diagrams. The arrow heads above are showing the skip metastasis. These are better picked up on MRIs. CT scan's usefulness is in evaluating the thorax for metastatic disease because lung remains the most common site for metastasis. Previously, the common staging workups included a CT thorax and a bone scan to check for bone metastasis. Nowadays, people are asking for FDG PET. If you look at the guidelines, the NCCN or the COG, the Children's Oncology Group, they recommend and or. So a bone scan and or a PET CTs. The usefulness of PET CT is that along with finding bone mets, it can pick up lung mets as well. PET CTs, however, has an additional usefulness in monitoring the response to initial therapy. I'll again come to it later on. Next slide, please. After you are done with your imaging, now you need to confirm the diagnosis. And this is one of the most important steps for managing bone tumors. Biopsy should be done after you are done with all your imaging. Need not jump to get a biopsy done. It should be performed by the operating surgeon who is skilled enough to manage bone tumors. Or if we're doing an image-guided biopsy, so a radiologist must consult with the operating surgeon. Why this is so is because there's a risk of seeding of the tract. So while doing the definitive surgery, during an oblong excision, the entire biopsy tract should be excised. Also, while doing the biopsy, you should avoid contaminating other compartments because by doing those things, you jeopardize the chances of getting away with a limb-sparing surgery. If you look at the picture, the black and white picture, if you're doing an open biopsy, it is recommended that you avoid a transverse incision, but do this kind of a small longitudinal incision. Nowadays, most often people go for a needle biopsy, and if needle biopsies fail on multiple times, they ask for an open biopsy. Needle biopsies must be planned meticulously, so you have to review the imagings and then decide where to enter. So the distance should be minimal and planned in such a way that the tract must be excised along with the tumor during the surgery. Careful hemostasis is mandatory. If you're drilling holes into the bone to collect tissue, it is recommended that you plug the holes because these hematomas can lead to spread of tumor cells. And you must yield enough, as is true for all tumors, enough tissue to permit complete histopathological evaluation. And while taking the biopsy, it is recommended that you take the biopsy from the areas which on imaging are looking as the most high-grade areas or the most aggressive areas on imaging, because your further management will be guided by your biopsy report. Next slide, please. Okay, so coming to the pathology, again, just a few words on it. So as I said, tumors are classified based on their morphologic features and by the matrix they produce. Osteosarcomas, they are bone-producing tumors. So they have presence of, so to diagnose OGS, you need to find presence of malignant sarcomatous tumor cells with production of osteoid matrix. 90% of osteosarcomas are conventional osteosarcomas. This is with regards to the medullary osteosarcomas, which can again be divided into osteoblastic, chondroblastic, or fibroblastic, depending on the predominant cellular component. There are two other varieties, the telangiectatic and small cell. Small cell variety is, reports suggest that they have slightly more radio sensitivity compared to the other varieties. Next slide. The previous ones were medullary OGS. There's another variety called the surface osteosarcomas. If you look at the pictures on the right side, the upper one shows a surface osteosarcoma, which is completely lying above the cortex. Those are called perosteal osteosarcomas. The periosteal ones, they lie just below the periosteum. So these are, again, only perosteal osteosarcomas are considered as low-grade osteosarcomas, where only surgery alone is enough. Rest all should be treated as intermediate or high-risk sarcomas and require, along with surgery, some form of systemic therapy. Next slide, please. With regards to Ewing sarcomas, well, they are one of those small round blue cell tumors. They tend to have sheets of uniform small round blue cells with hyperchromatic nuclei and scant clear cytoplasm because of the abundance of glycogen. There is usually extensive necrosis with preservation of tumors around the blood vessels. In peripheral PNETs, you tend to have more neural differentiation, and a vast majority express CD99, which can be used for diagnosis. Next slide. In bone tumors, we don't often use AJCC staging. It is less frequently used. Even when it is used, instead of TNM, we use TGNM, where G includes grade of the tumor. What is more commonly used is the MSTS surgical staging. MSTS is the Musculoskeletal Tumor Society. This staging was designed by Professor William Enneking. So there are 3 stages. It's very easy to remember. Stage 1, 2, 3. Non-metastatic cases are classified into 1 or 2, depending on whether they are intracompartmental or extracompartmental. So stage 1 would be intracompartmental, stage 2 would be extracompartmental. Now, what do I mean by extra or intracompartmental is whether the tumor extends through the cortex of the involved bone. 1A would be low grades and 1B would be high grades. So 1 is low grade tumors and 2 is the high grade tumors. These are again divided into A and B as intra and extracompartmental. Stage 3 is any distant or even a regional metastasis. Next slide, please. Okay, now let's move on to the management portion. Before we go into the overview of management, just a few words about the surgical principles of surgery and what all surgeries that we use often. Previously, for bone tumors, amputation used to be the standard treatment. However, the surgical management has evolved in a large way along with the emergence of newer effective chemotherapies. Nowadays, the emphasis is more on conservative surgeries so as to have better functional outcomes. So the emphasis is more on limb sparing surgeries instead of amputations, but always remember life before limb. So one should not be overzealous to spare limbs and compromise on outcomes or local control rates. However, with the newer effective multi-agent chemotherapies, limb sparing surgeries is now possible in majority of cases. Next slide, please. So what are the types of resection? If you look at this diagram, so the first 2 resections involves the joint. So those are called osteoarticular resection. So if the incision is performed through the joint, it's called intra-articular, which can be used for tumors in the metaphysis. However, if the tumor extends to involve the joint, then you have to do an extra-articular resection, where it resect the entire joint. However, for tumors involving the shaft, you can do an intercalary resection, where the bone alone is dissected while leaving the joint as it is. Next slide. This is a very contentious issue for surgeries involving bone tumors. This is important because the other prognostic factors are not controlled by us physicians, but the margin to a large extent depends on the work that a surgeon does. So it's kind of dependent on the surgeon. So that's why margin status itself is a very important prognostic factor. Again, Enneking defined the various criteria depending on the margin status. There are 4 varieties of resection. Intralesional, as the name suggests, you are cutting through tumor. Marginal is when the dissection or the dissection plane passes through the pseudocapsule or the reactive zone surrounding the tumor. So if you do a marginal resection, there is always a risk that there may be microscopic disease left behind. Wide resection is when the dissection plane is away from the reactive zone. MSTS recognizes a wide local excision as a standard approach. Radical surgeries is when you resect the entire bone of the myofascial compartment. Now, what is exactly adequate or optimal margin is a very controversial issue because there is no definite guideline mentioning. But again, consensus statements say that a minimum of 1 centimeter margin, ideally 2 to 5 centimeters, should be there around the involved bone. This is what the Children Oncology group also says. When it comes to soft tissues like fat or muscle planes, at least a 5 millimeter margin, and for fascial planes, at least a 2 millimeter margin must be there. Next slide. For extremity tumors, limb salvage can improve functional outcome without sacrificing local disease control if you can perform a wide local excision. So if you achieve an R0 resection and you use chemotherapy, limb salvage is is as good as amputation. Although there is no direct comparison between amputation and limb salvage, and I doubt there's ever going to be one. However, what is interesting is that available data does not show that limb salvage leads to better quality of life or better long-term psychosocial outcome. What is important is you need to choose your patients properly. So optimal patient selection is vital. So where you should not be attempting for limb salvage is if the tumor is encasing your neurovascular bundle. That is a complete no-no for limb salvage. The others are kind of a relative contraindications, is presence of large hematomas and pathologic fractures. Well, nowadays these are no longer considered as absolute contraindications. With induction chemotherapy, in case of pathologic fractures, one can very well achieve for or aim for limb salvage later on. Next slide, please. For non-extremity lesions, so those involved with the axial skeleton, they tend to have a worse prognosis because it's difficult to achieve a complete R0 resections, especially in the spine. As long as dural invasion is absent, one can probably achieve wide margins. For pelvic tumors, a pelvic tumor does not necessarily mean that one has to undergo amputation, because internal hemipelvectomy can be done preserving the extremities, whereas external hemipelvectomy requires a hindquarter amputation. Next slide, please. How to reconstruct? Well, there are several methods available, which includes metallic endoprosthesis. You have allografts, you have arthrodesis or fixation of the joints, you have vascularized grafts, and rotation plasty. Now, what reconstructive method you're going to use has to be individualized depending on where the tumor is, what's the stage or what's the extent of resection, what's the diagnosis, what the surgeon prefers or what the surgeon is expert on, what are the complications, what the patient wants, and your local logistics. Next slide. Just a few words about what these types of reconstructions are. This is a picture of a rotation plasty. So for skeletally immature child, reconstruction is a very challenging issue because of these vigoral functional demands and limb length inequality. So what is often done is a rotation plasty. So you see the ankle joint has been rotated by 180 degrees and is now kind of acting as a new knee joint. Later on, once the child attains skeletal maturity, a limb lengthening procedures can be done or reconstruction using a so later on it can be so that there is no limb length discrepancy. Or at times people use the expandable metal endoprosthesis, but it requires repeated lengthening surgeries. Next slide, please. Allografts are obtained from cadavers which are available in tissue banks. They have the potential for long-lasting reconstruction. The advantage is you spare uninvolved portion of the adjacent joints and you provide a site of attachment for host soft tissue. However, they have higher complication rates and early weight bearing is not possible with allografts. Next slide. The other commonly used is the metal endoprosthesis. Previously, we used to have custom-made implants. Nowadays, you have modular prosthesis, so which is fit to size. It allows for immediate joint stability and early weight bearing, but the complications have fractures and loosening and infections. Expandable prosthesis is often used in immature children, but you need to follow them up so that you plan your periodic lengthenings accordingly. Next slide. I'll skip these, move on. Okay, now I'll just briefly give you an overview of the management of common malignant bone tumors. So let's start with osteosarcomas. Previously, people used to offer only local therapies for osteosarcomas because effective chemotherapies were not available, and the majority, almost 90% patients ended up having distal failures. So long-term survival was pretty low, but with addition of chemotherapy, multi-agent effective chemotherapy, there is a drastic improvement in survival rates, nowadays achieving close to 70%. And you won't believe that standard of care has not changed significantly in the last 20 to 30 years. The other important thing is, even with patients having metastases does not mean that they're going to have an abysmal outcome. Close to 1/3 of patients with limited pulmonary metastasis may be cured with multimodality therapy. Next slide, please. So chemotherapy, as we all know, plays a very important role in the management of osteosarcomas. Optimal timing of chemotherapy, again, has not been established. So whether you give chemotherapy first, followed by surgery, or you do surgery first, followed by chemotherapy, again, there is no survival difference based on your timing of chemotherapy. But people often use induction or neoadjuvant chemotherapy, because as I said, if you're planning previously, when people used to use metal prostheses, they were custom made and they used to take time to make those prostheses. So in the meanwhile, so in that interval, people used to start giving chemotherapies. Nowadays, again, that's not much of an issue. So what is usually said is that if your decision to perform a particular surgery is not going to change, then you can do surgery upfront, or else you plan for induction chemotherapy, and then decide whether you can, because with induction chemotherapy, those who are not suitable for limb salvage upfront may become candidates for limb salvage after induction chemotherapy. The other important point is response to neoadjuvant chemotherapy is a major prognostic factor. But it is important that you remember that there is no evidence that outcomes in the poor responders can be improved if you alter the post-op chemo regimen. So what NSAT does, it kinds of identifies who are going to do well. So those who are not doing well with chemotherapy, there is no way to improve their outcomes. But again, you must complete those drugs in the adjuvant setting, because giving that drug is better than giving no chemotherapy in the adjuvant setting. What is the optimal regimen? Again, standard chemotherapy regimen includes these 3 drugs, the MAP regimen, which is high-dose methotrexate, adriamycin or doxorubicin, and cisplatin. Studies have shown that 3 drugs is better than 2 drugs. So that's why 3 drugs is the standard regimen that is followed. And studies have shown that adding 4th drug in the form of ifosfamide did not lead to a benefit. So that's why 4 drugs is no longer used. So MAP regimen is the common one. However, high-dose methotrexate is not easy to deliver. So you need in-house admission. The patient must have a very good renal function, because the methotrexate must be cleared off from the body as quickly as possible. So in Indian patients, the other protocol that is often used is called the OGS 2012 protocol, which includes 4 cycles of doxorubicin cisplatin in the neoadjuvant setting, followed by your local treatment, followed by 4 cycles of adjuvant chemotherapy using ifosfamide and cisplatin. Next slide.
Really sorry, Dr. San. Just a gentle reminder that we are slightly lagging behind.
Very bad. Okay, fine. I'll just skip these slides. Okay, so what is defined as good response to chemotherapy is more than 90% necrosis. Next slide, please. I've already mentioned these things. So what's the role of radiotherapy? Well, so radiotherapy is not of much use in osteosarcomas in a curative setting. It is only used in tumors with challenging locations where surgery is going to cause significant morbidity, like the scalvus or the sacrum. So there, radiotherapy may be a local counter option. No role of adjuvant radiotherapy, except in patients where you have an R+ surgery. Prophylactic whole lung irradiation is ineffective in the absence of systemic chemotherapy. Next slide, please. Extracorporeal radiotherapy is one form where you remove a tumor and you give very high dose radiotherapy, so that the dead bone is again placed back into the implanted back into the body. So usefulness is that you have the correct dimensions. This is one form of reconstruction that we often use. Next slide, please. I'll just set some diagrams anyway. So let's move on. Ewing sarcoma, again, similar to osteosarcomas, chemotherapy plays a very important role. Initial cytoreduction takes care of micrometastatic disease. Then you offer local treatment, followed by consolidation chemotherapy, to take care of occult residual disease. Standard chemotherapy for Ewing sarcoma includes these drugs, the VACD and ifosfamide etoposide. Next slide, please. So these are prognostic factors that presence or absence of metastasis. Lung metastasis has the best prognosis, followed by bone alone, followed by lung and bone. So patients with limited lung metastasis can still be considered for curative intent treatment. Large tumors, axial tumors tend to have worse outcomes. Response to induction therapy is an important prognostic factor and a completeness of resection. Next slide, please. This is a protocol that is commonly used in Indian patients, the EFT 2001 protocol. Again, if you have the slides, you can go through them. Next slide, please. This is a very, again, a debatable issue. What local treatment? Because unlike OGS, Ewing sarcoma is radiosensitive. So local control can be achieved by surgery or radiotherapy. Again, no head-to-head comparison between surgery and radiotherapy. There'll be vast majority of studies that show that local control with surgery is better, but the problem is there's a selection bias there. Radiotherapy was offered to patients with bulkier tumors in axial locations, which are anyway the bad ones. So the results were anyways going to be worse compared to the extremity lesions which undergo surgery. Next slide, please. This is important because it should be decided in an MDT. Remember, surgery and radiotherapy are not competing modalities, but complementary. So before you decide, keep in mind, where is the tumor? How old is the patient? What's the response to your chemotherapy? And then you have to look at the potential complications and what does the patient want. Timing is usually, people say that, so EFT 2001 protocol has 9 weeks of induction chemotherapy, which should be followed by the 10th week, you should offer your local treatment. Next slide, please. What are the indications of adjuvant radiotherapy? So very easy to remember, if you have an R plus surgery, or for patients with a poor response to NSCT, you may offer, because it improves local control rates, and cross contamination for pathological fractures. Again, this is a soft indication. Next slide. Previously, people used to treat the whole bone, but then studies have shown that you need not treat, but treat only the gross disease with margin. Recommended doses, very easy to remember. R0 disease, you give 45 grays. R1 disease, for R1 disease, you give around 50 grays. And for R2 disease or for definitive radiotherapy, around 55 grays. So what we do is, for phase 1, so the pre-chemo disease with margin receives 45 gray. And then to the post-chemo volume, you add 10.8 gray in 6 fractions. What about dose escalation? Well, there's a study from India. Dr. Laskar did a phase 3 study where he escalated doses to 70 gray with excellent local controls, which was presented in Astro in 2019. Well, the full paper is yet to be out. So once that is out, probably we need to deliver higher doses. Next slide, please. Does whole lung irradiation help in patients with lung metastasis? Well, there is no randomized trial that confirms the benefit, but yes, there are retrospective reports. We see that yes, a low dose whole lung radiotherapy improves even pre-survival. So around 15 to 18 gray in daily 1.5 to 2 gray fractions. Next slide, please. If you allow, this is the only slide there, or I can just skip this. Chondrosarcomas, again, surgery remains the mainstay of treatment. Just one word is that these are relatively radio and chemo resistant. Radiotherapy may improve local control in R plus dissections, but in unresectable cases, it's only palliative intent radiotherapy. You have encouraging results with proton and carbon ions. Very, very important is no role of adjuvant or neoadjuvant chemotherapy in chondrosarcomas. Next slide, please. So the take-home message is, as I said, these are rare tumors. You need a multidisciplinary approach. Believe me, we do have brainstorming sessions for challenging tumors. Imaging and biopsy are critical. You need effective chemotherapy, have vastly improved outcomes. Wide resection is the primary goal. The emphasis is more on limb salvage, but as I said, life before limb. Radiotherapy is an important local treatment modality for Ewing sarcoma, limited role in osteosarcomas. And do not forget this, bone tumors are preferably managed in tertiary cancer centers. Thank you. I'll be happy to take questions or if that is it.
Thank you very much, Dr. Sayan. It was a wonderful presentation, and it was really a tough job to cover such a vast topic within 40 minutes. We will take the question at the end of the session. Our next topic is soft tissue sarcoma, and our next speaker is Dr. Sandeep Sarkar. I would like to welcome Dr. Sandeep Sarkar for presenting on soft tissue sarcoma.
So much. So my presentation is uploaded. Hello.
Yeah. Hello.
Yeah.
So give me a second.
Yeah. My presentation is uploaded.
Yes, yes. Give me a second. I'm sharing this.
So we can start right now, right?
Yes, you can start.
Thank you, Monideepa. So I'll start from here. So hello, everyone. Today I'm going to talk about soft tissue sarcoma. In general, I'm not discussing about these trials and other things. So I'll only get a look of overall how to manage the soft tissue sarcoma in general. So if you look at the incidence and epidemiology, soft tissue sarcoma represents only 1% of all cancers. In 2015, estimated new cases of soft tissue sarcoma was 11,930, which is just 0.7% of all cancers. And deaths was 4,870. It is 0.8% of all cancer deaths. These STS are more commonly seen more than the age of 50 years, although seen in children and adolescents under the age of 20. Men are more frequently affected and rates are higher among African Americans than whites. Next slide, please. Someone's mic is open, I guess. So if you stop that mic, then the external noise will not come. So what are the risk factors? Most sarcomas arises in a sporadic fashion without identifiable cause. Associated factors are like predisposing genetic factor like Lee-Frowney syndrome, P53 gene, and NF1, ionizing radiation exposure, industrial chemical exposure. Next slide. So if we look at the distribution, this most of the common site is the thigh. Basically 44% is seen in sarcoma, soft tissue sarcomas arises from the thigh, and second most common part is the other lower part, including the lower limbs, lower leg and calf around 10%, then shoulder around 11%, upper arm 7%, forearm 6%, and other upper portion of the body is 5%. So most commonly it is seen in thigh, and the lower part of the body, these soft tissue sarcomas. So if you now come at the classification of the soft tissue sarcoma, these sarcomas are a heterogeneous group of tumors arising from the mesenchymal cells. More than 100 different histopathologies are there. It is not possible to include all these different histopathologies and talk about all these histopathologies. Diagnosis made on the morphological pattern with aid of immunohistochemistry staining. Many have distinct chromosomal translocation. Many have implications for tumor location, behavior, and treatment. Next, please. Something is coming in between.
Try to notice.
So, what? Go back one slide, please. Yeah. Next slide. So, let's talk about the most common types of sarcoma. What are the most common types? The pleomorphic and round cell and spindle cell are the most common types. These are undifferentiated or unclassified sarcomas. And then liposarcoma, synovial sarcoma, leiomyosarcoma, MPNST, malignant peripheral nerve tumors, rhabdomyosarcoma, primitive neuroectodermal tumors, extraskeletal wings, angiosarcoma, epithelioid sarcoma, clear cell sarcoma, alveolar soft part of the sarcoma, and solitary fibrous tumors. So these are the most common type of sarcomas we see in general, and there are a lot of other rare variety of sarcomas. So we'll not talk about all those sarcomas right here. Next slide, please. So if we look at the staging, the most the T staging, if we look at the T staging, tumors less than 2 centimeter or less is T1. T2 is tumor more than 2 centimeter, but tumor more than 2 centimeter, but less than 5 centimeter. T3 is more than 5 centimeter, but less than 10 centimeter. And T4 is tumor more than 10 centimeter in greater dimension. And N1 is regional lymph node. Any regional lymph node is present. So here, if you look at the staging, stage 1, 2, 3, the most important is stage 4, where any node is present with M1 is stage 4. So this is the most important part. So stage 4 cancer, if there is a nodal node present, so it is stage 4 cancer. Next slide, please. So there is a grading system. Grade is the most important part of soft tissue sarcoma. But there is an external sound is coming from somewhere. So so can
Okay, I'm
you,
trying to move.
someone mic is open, I guess. Switch off all the mics, then it will easy for me to talk. Anyway, so grade is the most important in synovial sarcoma. What happens with the grade? It depends on is a tumor differentiation, is a well differentiated or moderately differentiated or poorly differentiated. Then comes the type necrosis, the pattern of necrosis is less than 50% or more than 50%. Then mitotic cell counts. So number of the cell is present in the high power field. So if it is less than 10, it is 1. In 2, it is 10 to 19, and in 3, it is more than 20. So this is NCI grading, where histology, location, and tumor necrosis is the important part for this grading system. And some tumors, some sarcomas do not have this grading system because it's already high. What are those sarcomas? Like MPNST, epithelioid, clear cell sarcoma, angiosarcoma, external myxoid chondrosarcoma, and synovial sarcoma. All these sarcomas are already high, so the grading system is not always important in these sarcomas. Next. So Let's come to the clinical presentation. So how sarcoma presents? If you look at the extremity, the patient comes with enlarging painless mass with pain. Sometimes pain is not there. Sometimes pain is present with functional limitation. That is most important part. Another important part, symptoms associated with compression of the local structure. Next. If there is a mass in the retroperitoneum, so how patients present? The patient presents with often it is incidentally found associated with pain, some gastrointestinal symptoms like early satiety, obstruction, bleeding, and lymphedema, neurological and musculoskeletal symptoms may be present. Next slide. So how to evaluate this soft tissue sarcoma? So most important is the core needle biopsy. FNAC never recommended. So that's why I have cut the FNA. So core needle biopsy is the most important. It should be taken from multiple samples. Site of the biopsy is most important. For representative sample, CT or ultrasound guided core needle biopsy to be done. Incisional biopsy, if it is required, it should be done by the surgeon, because ideally by a surgeon who will do the definite surgery should go for this incisional biopsy. And longitudinal in extremity and adequate hemostasis is required during this incisional biopsy. Next slide, please. So staging evaluation. So in staging evaluation, the most important part is the histopathology. In histopathology, we get the type of the tumor, type of the sarcoma, the grade of the sarcoma, as well as its tumor necrosis present and whatever the score we get. Along with this, evaluation of the primary site is required. So if the tumor is present in the extremity or superficial trunk, MR should be done. And for the retroperitoneum as well, we should do CT scan. And for the distance metastasis to rule out, we know the sarcoma goes to lung, and so we have to do CT chest with or without contrast. Bone scan or PET CT scan usually not required. Next, please. Now look at the soft tissue sarcoma, the pattern of spread, how it spreads. In extremity sarcomas, it spreads along the longitudinal tissue planes with the component. So with the compartment, within the compartment it goes. It involves the nerves, vessels, and can track along. We can track along with these nerves and vessels. It compresses, distorts the adjacent soft tissues. Tumors can be well beyond the mass. So here we can see the subcut pleomorphic sarcoma, where it is in the peripheral region, where it is in the compartment. So you can see this deep MPNST. Next slide, please. The prognostic factors for for survival. What are the prognostic factors? Grade is the most important. Then size, it is 2 to 5, more than 5, less than 10, or more than 10. So size is most important. Then depth is superficial versus deep to fascia. Site, which site it is present, it is in the extremity versus trunk or retroperitoneal. It is distal versus proximal. All has got importance in the prognosis as well as the survival. Lymph node involvement, if there is a lymph node involvement, it will be a stage 4. Already I have mentioned. So lymph node involvement also important for prognostication of this synovial sarcoma. Another most important is the age. Poor outcome in older age group is seen. Next slide, please. What are the other prognostic factors for local recurrence? Is the marginal resection is important, along with positive margin, locally recurrent disease, head and neck, and retroperitoneal location. So these are the prognostic factors for local recurrence. Next, please. So any sarcoma should be managed by a team. The hospital or the institute should have a team of radiologist, pathologist, surgeon, radiation oncologist, medical oncologist, and physiotherapy. So these are a team where radiologist has a role in biopsy and structures involved. We have to sit with the radiologist and have to see the images to find out which compartmental disease it is, what are the nerves involved. So radiologist has a big role, including the biopsy. And pathologists do the most important thing is the typing of the tumor and grading along with the IHC. So we need a very experienced pathologist along with the.
What was it like to work at home? I think it was fantastic. I think it was just absolutely
Hello,
fantastic.
I request to mute all the
I think if I
participants.
ask you
Mute
between
except
Raja
the
and
speakers.
Nenman, what do we say? It's the same thing. I mean, they're two different kinds, but they're just fantastic. And such a dream to have an actor on the set who.
Sorry, hello. Should I continue?
Yes.
Yeah, go back, please. Yeah, just go back. Yeah. So I will ask everyone, please mute your mic, those who are listening. And if you guys have any question, please ask after I finish it up. So the management of this multi-modality team is very important. Surgeon has a role. Oncosurgeon, plastic and orthopedic surgeon is required. Radiation oncologist, medical oncologist, and physiotherapy team for rehabilitation is very important. Next slide, please. So the soft tissue sarcomas, surgeons need to see whether this tumor is operable or not. So what are the surgical resectability issues? If you look at that, the vascular involvement is there or not, joint involvement, tissue plane adjacent to the bone or not, functional loss, need for plastic surgery or hand surgery. Next, please. Therapeutic goal for sarcoma treatment. So this is the most important slide. So whenever the patient comes to us, what is the therapeutic goal for us? The goal is maximize the local control and survival, conservation of the limb, and achieve optimal limb function. Next, please. Role of radiotherapy. Radiation allows for successful limb conservation treatment. Radiation offers absolute local control benefit of 20 to 30%, and local RT improves the overall survival. Next, please. Pre-operative so can you move this, please? Move the window. The principles of radiotherapy. Go back. So situations are, what are the situations the radiation has got a role? Like pre-operative, intraoperative, and post-operative. What are the techniques for external beam radiotherapy? It could be given by conventional way, PDCRT, IMRT, IGRT, and proton therapy. And it can be given only brachytherapy alone or brachytherapy plus external beam radiotherapy. Next slide. Indication for radiation. So indication for radiations are all high grade, large and marginally excised low grade benefit with adjuvant radiotherapy. What happened? I will ask everyone, please mute your mic, please. So surgery alone can be treatment for if the tumor size is less than 5 centimeter, low grade or superficial tumors, widely excised with acceptable margins, margin more than 1 centimeter or less. And surgical planes should have transverse normal tissue outside the reactive tumor zone. Next slide, please.
Give me a second, sir. There's some technical issue. Some vendor is coming. I have to do that.
Hello.
Yes.
Am I audible? Hello. We need to move this. Something is coming in between. Should I share myself the slides, Monideepa?
Yes, sir. If it is
I'll
possible,
do.
then, or otherwise, I'm trying to do it from here again. Is it okay now?
Trying to share the slides. Guys. Is it visible?
Not yet visible, sir.
Not yet visible, right? So share screen. Let's start. I think Mohideep, you continue.
Yes, yes, yes.
I'm not able to do that.
Now is it
So
visible?
we're talking about the go back. So role of radiotherapy we are talking. So what are the indications for radiotherapy? So it is in 29. Yeah, and the next slide. Yeah. So next slide. Yes. So before we go talk about the indication for radiotherapy, the surgery, what are the indication for surgery alone is possible if the tumor size is less than 5 centimeter with low grade and the tumor is superficial tumor with widely excised and acceptable margin where the surgery is okay. So you don't have to give adjuvant radiotherapy. But when we require adjuvant radiotherapy, all high grades, large and maximally excised low grade sarcomas benefit with adjuvant radiotherapy. Next, please. So make it big so that. So there is a impact of adjuvant radiotherapy on overall survival. That's SEER database of 6,960 patients. They have given radiotherapy to the extremity, treated with limb sparing surgery with or without radiotherapy. It was a 3 years overall survival data where low grade, there was no difference in survival, but in high grade, no radiotherapy, 63% of OS benefit, whereas with post-op RT has 73%. And if the tumor size is more than 5 centimeter with high grade, no RT has got 3-year survival is 53% only, whereas in post-op RT it was 66%. In both the places, the p-value was very significant. Next slide. So the pre-operative radiotherapy versus post-operative radiotherapy is a big controversy. Many people believes pre-operative radiotherapy has got a big role for overall survival and all. So we'll discuss this in this slides. So pre-op RT, what are the issues? Go back. The issues of pre-op, it decreases the tumor spillage during surgery. Thickened acellular pseudocapsule helps R0 resection. Wound healing delayed, but the issues are wound healing gets delayed and next 6 weeks needs 6 weeks gap between the radiation to surgery. So surgery gets delayed sometime. Evidences from the randomized control trials, local control is higher in pre-op RT, it's marginally higher. Overall survival is also marginally superior in pre-op RT. Significant long-term post-op complications are seen in pre-op RT, more than 120 days. Post-op RT helpful in unknown margin and pre-op RT helpful in cross primary disease. So these are most important difference between the pre-op and post-op RT. Next slide, please. So pre-operative versus post-operative radiation. Again, we look at this complications and toxicity. More acute wound complication is seen in pre-operative RT, and these are usually reversible. Whereas in post-operative RT, more long-term edema, fibrosis, and decreased ROM is seen. So usually irreversible, these are. So equivalent efficacy with different toxicity. So treatment option should be individualized. So whether to give pre-op or post-op RT, it should be individualized to patient. Next slide, please. Brachytherapy as a monotherapy. So brachytherapy has got a very good role. It is given in high-grade lesions with complete surgical excision with negative margin patients. Usually the tumor size should be less than 10 centimeter. Regions that can be encompassed well with brachytherapy catheters. Pediatric sarcomas it is used, and previously irradiated patient also sometimes we do brachytherapy. Next slide, please. Adjuvant RT in negative margin, high grade T1, post-operative RT is more than 2 centimeter must. T1 is no RCT is done, but interstitial brachytherapy is superior versus no adjuvant RT. And in low grade, post-operative RT may be avoided in all must be present superficial and less than 5 centimeter with R0 resection. Next, please. Soft tissue sarcomas treatment issues. What are the treatment issues? So most important is the motion. So we need to do fixation. So customized immobilization is required, not the standard immobilization what we do for head and neck, thorax or abdomen. So there should be a customized immobilization for each and every patient, because the proximal extremity needs stop motion. There are skin folds, there is genitalia is in just beside the thigh, there's a genitalia, so there is skin folds, so there will be more toxicity. So customized immobilization is most important, along with distance of the arm to head. Next slide. So you can see here is a customized immobilization made for this lower extremity, distal extremity, fixation to prevent rotation and move other lower limbs. Here also customized immobilization for the upper extremity. Next, please. Soft tissue sarcomas, and there's another is mid extremity where the tissue should be dependent. So this is the where you can see in this picture, it's dependent, so that the movement will be less. Next slide, please. So let's come in the dose volume for pre-operative versus post-operative radiotherapy. Pre-operative radiotherapy, lower dose is 50 gray, smaller irradiated volume. CTB is GTB plus 4 centimeter longitudinal margin plus 1.5 centimeter radially. Post-operative radiotherapy, higher dose 60 to 66 centimeter, large irradiated volume. CTV is cooperative bed plus 4 centimeter longitudinal margin plus 1.5 centimeter radially. Next slide. So here we can see the volumes. Next, so this is a post-op RT targets. Next, please. So post-op RT targets, what should be the CTV? CTV is a shrinking field technique. Initial volume is surgical bed reconstructed from pre-operative imaging. We have to collect the pre-operative image so that we can contour it correctly. Fusion of pre-operative MRI with post-operative CT image. Further evaluation based on post-operative changes, operative and pathology report, surgical clips. Expand volume 1.5 centimeter radially and 4 centimeter longitudinally. Next, please. Previous one. Previous. Yeah. Post-op RT target, boost volume, small as initial volume except in the longitudinal, use GTV reconstructed with 2 centimeter margin. Other issues are scar drain site to be included. Low risk situation, drain site could be omitted. Next, please. Radiation issue. What are the radiation issues for the retroperitoneum soft tissue sarcoma? Like volume, patient GI stability, ability to spare normal tissues, low kidney plans and function, pre-operative versus post-operative. Next. Post-operative RT rarely can achieve adequate dose, more GI toxicity. Pre-operative RT is preferred. It has got advantages: tumor readily identifiable, tumor displaces bowel, peritoneal tumor reduction, pseudocapsule formation, margin improvement, and typically a lower dose is felt to be needed. Next, please. So GTB, previous one, the GTB with muscle extent. Can you move this so I can read it out? CTV, GTV with 2.2 into 2.5 centimeter margin, superior and inferior. GTV with 1.2 centimeter margin radially, exclude bone, kidney, and liver, include rim of the adjacent bowel and air cavity, and include any disease extending to the lingual canal. Lingual canal has to be included. Next, please. Next slide. So radiation, what are the doses for pre-operative? It's 50 gray external dose, and it includes the surgery with the clips. So consider boost to the post-operative. Intraoperative boost also given 10 to 12.5 gray for the microscopically positive margins, and 15 gray for cross disease. And pre-operative party 45 to 50 gray in 25 to 28 fractions to enter CTV with those pens, including and boost up to 57.5 in 25 fractions. So next slide. Adjuvant chemotherapy. Adjuvant chemotherapy cannot be recommended as a standard of care for all patients. First meta-analysis of adjuvant chemotherapy using doxorubicin-based chemotherapy showed a significant benefit in local recurrence-free survival, but no significant benefit in overall survival. It may be considered in a select population with high-grade extremity sarcoma with more than 5 centimeter or recurrent high-grade tumors. Next slide, please. 40% eventually recur at distant sites, of whom 90% will ultimately die of this malignancy. So median survival with metastatic disease is about 12 months. Palliative chemotherapy should be considered with good PS with single agent chemotherapy, preferably doxorubicin. Other chemotherapy regimens like ifosfamide, paclitaxel, gemcitabine, etc. A lot of chemotherapies are there, but single agent doxorubicin preferred. But there was no level 3 evidence, only level 2 evidence we have regarding this chemotherapy. So these are the chemotherapy regimens of NCCN guidelines. There are multiple chemotherapy regimens, but all has do not have level randomized control in trials. Next, please. So these are the angiosarcoma, paclitaxel, docetaxel, vinorelbine, sorafenib, sunitinib, TKI also used, bevacizumab they are using. So next slide, please. In unresected soft tissue sarcomas, primary is if the surgery is not possible, then primary radiotherapy dose can be given up to 70 to 80 gray, or chemoradiation, or chemotherapy with ifosfamide with doxorubicin. Isolated limb perfusion or isolated limb infusion can be tried. Next slide. So in summary, diagnosis of soft tissue sarcoma based on pattern of recognition and pattern of analysis into the brown revolution of IHC and embraced the next molecular genetic revolution. Diagnostic workup should be done with core biopsy, primary site MRI with CT thorax. Multimodality team approach should be done. Therapeutic goal should be maximize local control with overall benefit with limb conservation. Pre-operative versus post-operative radiotherapy option should be individualized. Adjuvant chemotherapy in soft tissue sarcoma still remains the area of controversy. Thank you.
Thank you very much, sir. It was a wonderful and lucid presentation. Now we are moving to our last session, and we are lucky to have with us Dr. Rimpa Achari to speak on pediatric malignant solid tumors. I think ma'am need no any further introduction. Ma'am, please, you can begin your presentation.
Thank you, everybody. And I think my screen is visible to everyone.
Yes, ma'am, it is visible.
Okay. And at the outset, a very good evening to all of you. And even at this dinner time of 8:30 to 9 p.m., I see about 64 people who are students and the most important colleagues for the current generation with us. And I thank you, the West Bengal AROI, for giving all of us an opportunity to teach. And to all students who, at the outset, I would like to tell you that in radiation oncology or in clinical oncology, nothing is limit. Nothing is the limit. I mean, you all are JRs, and if you are really passionate about reading and understanding, then you can achieve everything that you have ever thought about. With that little introduction, I have actually set a stopwatch for myself so that I don't go on and on. And we will discuss over the next 25 to 30 minutes. It is a loaded presentation because pediatric tumors are a different ball game. And the stage has been very well set by two of my very good colleagues, Dr. Shayon and Dr. Shondip. And I would also like to mention here that pediatric solid tumors is actually beyond the gambit of basic training. And most centers across the world teach pediatric radiation oncology as a part of senior residency or even a post-residency fellowship program. So don't get worried by the jargon in the slide or the amount of information that I will show, but it is important to understand the structure to approaching these patients. And children are always, very interesting to treat, very challenging to treat, but the results are most often very rewarding. I would only request all of you to keep a note of the little cartoon that I have put up for TMC Kids. And I will come to why the logo at Tata Medical Center for Pediatric Radiation Oncology, or rather Pediatric Oncology, looks like that in the next few slides. You will also notice that you all had received an email with attachments to the structure of the presentations this evening. And I have adhered to the topics that were set by the respectable organizers. So you can actually look at the Word document and look at my slides. So it's exactly what has been expected of a speaker. With that, let us look at the incidence of disease. And classification of incidence per year for any cancer largely comes from GloboCan, which is the Global Observatory for Cancer. It is a document which is freely available online, and I will encourage every student to read GloboCan. It is very interesting to see how the disease incidence changes over a period of time. And these are non-communicable diseases, that is malignancy, but how very closely it follows the pattern of diet, of exercise, of whatnot. But again, having said that, you will find that for pediatric cancers, there is hardly any epidemiological association, and that is what sets pediatric cancers apart. I'm sure that you've already had a very good teaching on brain tumors. I think it was last week by Shumon. I thought I would log in and then I got caught up. And today we are going to discuss, we've had good discussions on sarcomas and on bone tumors by Shayon, but we'll move on to other tumors which are of importance, not because they are common tumors, but because they have implications in cure and in implications of therapy-related side effects. Having said that, adults, what are the basic differences? I mean, as students, we first understand fundamentals before we get on to management. So you all know that adults have post-development mature tissues. Most of the tissues in our bodies are completely mature. Children, on the other hand, have a mosaic of tissues, developing organs and mature tissue systems. Adults generally get cancer of places where their body sites interact with environment, sun exposures or oral environment in contact with tobacco, etc. In children, that is not the case. In children, as my previous speakers have mentioned, various kinds of mutations in bone tumors, or Shondip's mentioned in soft tissue sarcomas, they are intrinsically occurring mutations in children, which either provoke oncogene activity or they make tumor suppressor genes inactive. So that is the fundamental principle behind cancer genesis in children. You also know that epithelial tumors are very common in adults, whereas epithelial tumors are very uncommon in children. Tumors we mentioned above, because mature tissue predominance in adults, tumors arise from mature tissues in adults. And you also know that embryonal malignancies are very common, and we will be discussing rhabdomyosarcomas, which is a signature embryonal malignancy classically seen in children. So what are the basic principles and challenges in the treatment? Majority of the children must be or are often treated according to very standard protocols. You know, at times I do get phone calls from colleagues and my friends asking what dose should I use? And often I tell them that please use doses according to the standard protocols that you are using. And if it's a standalone center that you are practicing in, we will request that you, like Shondeep rightly said, please refer to a tertiary care center. That often makes me unpopular, but please remember, as students or as community physicians handling very critical cases, it is not popularity that a doctor must look at. It is the safety of the physician or the treating team. And I really feel very proud this evening that West Bengal ARI has really made an effort to improve the standard of education in this state. So international cooperation, as my previous colleagues have mentioned, really contributes to quality assurance, and very few sites exemplify this international cooperation, but pediatric cancers. So combined therapy optimization according to diagnosis and age is essential, and active interdisciplinary supportive measures have been elucidated by my previous speakers time and again. What is fundamental to teaching and education of late, I would insist that even if you are a GR1, it is important to feel inquisitive about how molecular biological research has integrated to improve the quality of care and adapt therapy. Cooperation during treatment across sectors is very important. So is knowledge and experience, like we just mentioned, which are involved in patient care. Availability of robust disease management groups, again, very well elucidated by Shondeep and Shayon, are essential. And I am very happy, and I see that most centers in our state now have disease management groups, and that is the fundamental to safety. Disease management groups are a mixture not only of doctors, but colleagues from various expertise, and that is the basis of curing these children. The other thing which I feel often is lacking across various patients that come to us for treatment is lack of providing full information. So I think as doctors, even if the outcomes are poor, that is even more important, or good, it is essential to provide full information to the family and the patient. And something that is very limiting for pediatric cancer management across the world is the cost of treatment. For the basic approach to management, it is specific therapy of the underlying disease in pediatric cancers is often divided into induction of remission, consolidation, and maintenance. And that line very beautifully describes treatment across these cancers, be it hematological malignancies, be it solid tumors, etc. That is the basic principle that is often followed. Therapy of complications and side effects is our equal responsibility. We cannot shed our responsibility of complications if that has arisen as a part of treatment, and therefore providing full information at the beginning and during treatment and taking families into your, the circle of belief is extremely important. Please guide and provide information to children, especially adolescents, and of course their parents. Stepwise orientation to therapy is extremely important. So when we counsel in the OPD, children get treated often over a period of many months and even years. So we usually tell people, and these children at diagnosis are more sicker than after induction. So we usually tell our families that we will guide you as we go along, but this is the rough outline of care. Please always show openness in favor of a very sick child when you think that you need a second opinion. There is no harm to say that a second opinion is desirable, or you can please go and see this person. And, mutual pride should not come in the way of providing right care to any child, or in the sense for any patient. And a close-knit community like ours, we actually must look after each other rather than compete with each other. So emphasis of our treatment is to enable cure for the child and to lead a life which is as normal as possible. Having said that, let us jump into the topics for the evening. Challenges in treatment. I was supposed to speak on challenges in treatment and behavioral therapy, requirement for anesthesia, etc. And please recall the cartoon that we saw on my cover slide, that it was a little bald kid playing with a drum. And behavioral therapy, the story behind that kid is behavioral therapy. So I had this child with leukemia with testicular cancers who would only come to the radiotherapy department without crying or throwing a fit if he was beating a drum. And it was so exceptional. So we managed to get away with anesthesia, but that's a different story. He did bite me during setup one day. That was the very first time that we took him, but gradually he's become my best friend. So behavioral technique of differential positive reinforcement. So I insisted that I will put on the absolute technical terms because as students, we have to get used to complex terminology to get our fundamentals very strong. And shaping is a behavioral psychology technique which often eliminates the need of anesthesia. Physician personnel and equipment orientation is the key to adequate treatment. Praises, toys, triggers, reward, that is what I'm talking about. So what are the goals of anesthesia or sedation? Patient immobility, you know that is key to radiation delivery. Rapid and smooth onset of anesthesia. You don't really want to wait for 15 minutes on the machine because you have another 100 cases lined up for the day. Sufficient muscle relaxation so that the children are not rigid and imaging is well matched. Prompt recovery, of course, we want children to get back quick on their feet, go home, eat well, so that nutrition doesn't suffer when you're treating them every day. A bit of residual anesthesia and antiemetic effects are desirable to prevent added medications. And we all know about drugs that have low tachyphylaxis should be used. Cost effectiveness is a challenge because daily anesthesia is definitely expensive, or cumulative cost is definitely a factor. But then again, we counsel patients that it is cost effectiveness versus safety of treatment delivery. Continuing with challenges of delivery for radiation and chemotherapy. Radiation therapy, has fitting and wearing aids concerns like masks, making vacuum bags for the children so that we can make them lie down in the same position every day. Unfamiliar machines, Linacs, etc. are not, they don't look like standard ultrasound or CT machines, etc. So they are unfamiliar machines to most families. Forms of treatment that are difficult to comprehend. We often have patients asking, ki, ma'am, dikhega bhi nahi, sunai bhi nahi dega. So how do we know that we are getting treated? So it's up to us to discuss and teach them how we know that they are getting treated. Being alone during radiation, I think this is absolutely unique to radiation therapy. You would all agree. And then dealing with radiation-induced acute and late effects like we discussed in my previous slide. Radiation or chemotherapy for children are often long duration treatments that cause physical and emotional exhaustion to the patient and their families and caregivers. They have altered appearance. If you have a 15-year-old getting treated for an Ewing sarcoma, post-chemotherapy, limb dysfunction, post-surgery plus minus radiation therapy, it is a major concern for them, especially for the adolescent group. Psychological changes. High-dose corticosteroid is one of the commonest causes for psychological changes during and after treatment. And postponement of treatment, complications are not uncommon, and most often treatment gets further prolonged. And therefore, as treating teams, we have to treat these patients with patience and empathy. Separation from family, brothers, sisters, pets, school, friends. So all these are very real for treatment of pediatric cancers, where only when you get into it, you will know how difficult it is for both the treating team and the patient and his family who's undergoing treatment. And of course, parents' own problems at work. In continuation to challenging treatments, therefore, it becomes essential for all of us to strategize and minimize long-term treatment-related side effects, especially in context of radiation therapy, because today our teaching focuses on radiation oncology students, although we have very well blended in concepts of clinical oncology. So radiation damage. What underlies radiation damage is parenchymal cell loss and destruction to underlying vasculature and stroma. This requires an understanding. So safe delivery of radiation therapy requires an understanding of pediatric tissue, its tolerance to radiation therapy, and that defines how you prescribe total dose, dose rate, dose volume distribution, and age-specific organ constraints. Like Shayan said very rightly, and he beautifully said, he kind of displayed a menu card for JRs. The JR1 should know this well, the JR2 should know that well. And this, I think, is the gambit of either our JR3s or SR1s or even fellowship students to understand how tailor pediatric radiation doses. But I think it's been a very good move to prime our junior most colleagues to the nuances of pediatric oncology. And examples of knowing such things would be knowledge of ossification centers when they close, and that would define the constraints. And we all know the brouhaha about hippocampal anatomy, which is so beautiful and so intriguing, and the constraints that you use. I would want to bring your attention, dear students, to the graph on the right. If you look at the cumulative mortality incidence, which is the x-axis, which is the y-axis, versus the x of time since years of diagnosis, you will see that the cumulative incidence of death because of non-cancerous causes nearly reaches 10%, or if not 9%. And therefore, sequelae from radiation therapy or combined modality therapy is actually very real. This is another set of figures that show the kind of growth patterns of tissues according to age and the dysfunction or modeling of IQ scores, the drop in IQ scores since radiation therapy. It just exemplifies. So I'll put it very simply that the younger the age of the child, or the more the growth potential of the age of this child, if you radiate a patient at that particular growth potential, the mortality will be highest at that organ site. So what should underlie proper radiation therapy for children, or rather for any site, is multimodality image registration that you're often fusing with your planning CT images, information from MRI. If you don't have co-registration, please use a safe manual, visual transcription, correct segmentation or contouring as it is commonly known as, and class solutions for therapy for every site, and that is essential. Plan evaluation is always a balance between tumor control and toxicity. With that, I think the importance of psychological support and quality of life maintenance is extremely important, and it addresses two overarching concepts. So it's conciliar psycho-oncology, where the staff is called in only in cases of emergency, and this is not one of the best ways to do things. It is good to have alliance with the psycho-oncology team right from the beginning, and this helps us in our practice at Tata Medical Center considerably. And I'm sure that it does so for all of you who so beautifully practice pediatric and radiation oncology in the city. The most important tasks we have discussed already are provision of information, conduction of tests to identify disturbances, and then solve those problems. What has helped us in Tata Medical Center is also hospital schools. So we had a little hospital school before the pandemic, and we had teachers who came in the evening to teach our children, but that had stopped because of the pandemic. And once we are all vaccinated and the vaccination extends to general public, we will go back into it, and education through art and play. Collaboration with family physicians is extremely important, and so it is with school administration. So now we are 10 years into service in our hospital, that is. And we have a number of systems in place where school administration gets involved in follow-up of these patients, and that is really helping their education. So ours is not to treat alone, but also to provide rehabilitation into society. So with that little background, that is the fundamental to pediatric oncology. I will quickly go through the tumors that have been given to me for this evening. Coming to Wilms tumor. Wilms tumor is about 6% of all neoplasias in children. Majority of the children are less than 5 years old. They have a number of chromosomal associations or congenital syndromes. In pathology, these tumors are often gray to pink in color with a capsule, and this is important because capsular penetration changes stage. Tumor growth is often seen in renal veins for advanced stage disease, and bilateral Wilms is seen in about 5 to 7.5% cases. These are very challenging to treat. The basic components on which tumor pathology is grouped are epithelial, blastomal, and stromal. Clinical features, usually mothers bring children with an abdominal mass. Mind you, palpation must be done with care because it has the potential to milk tumor either out of the capsule or into the renal veins. Unclear febrile episodes, hematuria, hypertension because of renin, very rarely polycythemia or symptoms of metastasis can be the first presenting symptoms. Don't look at the right. That is the stage and the description. You can always read that in the book, but I'll just bring to you the fundamentals of any staging. It is either confinement to the organ, the extents of resection, the extents beyond the margin, beyond the organ of origin, extent of surgery defined by gross residual or no residual tumors, and of course, stage 4, you know, is hematogenous. So this forms the basis of any staging. How do you approach these children? That is especially for our JR1s. You would have labs which is specific to the tumor diagnosis, especially 24-hour urine catecholamines, urine examination for bloods for basic kidney function, and hematology is essential for Wilms. Radiological diagnosis extremely important, and standard of care is CT of whole abdomen and thorax, angiography especially for nephron sparing surgeries for bilateral Ewings, and of course metastasis directed imaging. This is a busy slide, but I had no choice but to put it up because this is a teaching session. Prognosis we discussed depends on stage and histology, and I would encourage you to read through the slide. I will not read through these because it will really take away our time, and most of you would drop out of the meeting because it would be boredom. But unfavorable factors for Wilms tumor are largely diffuse anaplasia, nodal involvement, vascular involvement, or tumor rupture. And of late, you know that all of the major series have incorporated the loss of heterozygosity on various chromosomal arms and mutations in chromosomes which are poorer, carry poorer outcomes. The principles of therapy for Wilms tumor comes largely from two cooperative groups, the European group, which is the PSYOP, although I'm not supposed to discuss evidence, but this is fundamental, we must know this, is the PSYOP group, that's the European group, and the other group called the NWITS or the NWTS, that is the Canadian North American group. And the basic difference between approaching Wilms tumor in these two groups is the NWITS looks as primary surgical resection followed by adjuvant treatment, and PSYOP looks at preoperative chemotherapy. So it's usually transabdominal tumor resection is the fundamental to surgery with biopsy of nodes. Most active drugs are vincristine and actino, and most primary metastases are treated with the addition of anthracyclines. The indications of radiotherapy, I thought we must know what are the basic indications, and that it's usually stage 2, not all stage 2s are treated, but stage 2 with nodal involvement. Advanced stage disease 3 and 4, especially to pleural and abdominal disease and lung. And we can go on, and I'll be happy to share my teaching slides with the society so that they can share it within the JRs to understand how radiation therapy is decided upon and treated. What is also of fundamental importance is all the cooperative group studies, be it NWITS or PSYOP, has proven beyond doubt that the best outcomes are seen within the first 10 days, post-operative days of radiation therapy. First 10 days of surgery, if radiation starts, that gives the best outcomes, although PSYOP goes up to 2 weeks of acceptable time. This is just a pictorial representation so that you understand that pediatric oncology with the use of anesthesia, our threshold for anesthesia is pretty much low, especially when we are treating children with flank boost when there is only one kidney, and any misalignment, etc., you may just land up treating a lot of other normal renal tissue. And it's important to have child specific devices. So these are pediatric pulse probes that we use, and that is how a classical children, a child who's undergone Enwith's staging system in our hospital looks like. So we usually make a VAC lock. So there are all pediatric specific probes attached. So we usually stick in a central line right in the beginning so that we don't have to prick children again and again. And because we are within 5 days of surgery, the dressing is on, and this child will go in for whole abdominal radiation therapy. And mind you, we finish in during anesthesia all painful procedures so that the children are not given pain again and again. That is a standard portal, although we are not supposed to discuss portals today, but I just thought I'll give you a flavor that it's important to cover the diaphragmatic surfaces on top, and it's important to cover, to respect and protect growth plates. That is how a whole lung radiation looks like. Coming to neuroblastoma, I won't spend much time on neuroblastoma, although it is one of the most common malignancies. I will just draw your attention to the fact that chromosomal changes and karyotypic abnormalities are fundamental signatures. And the older children usually have amplification of the MYC and oncogene, and that brings a poor survival. And this again, I thought I will put it up for the GR1s because Shayan so beautifully said that as GR1s, we need to read radiobiology. And if you read the MYC-N amplification biology, you will see that it has implications both for chemotherapy as well as for radiation. So neuroblastomas are common children, but here it's a busy slide and I would share this presentation with all of you. But I will tell you that our approaches are very standard. We have patients presenting with very common symptoms, often symptoms of catecholamine overproduction and paraneoplastic syndromes. We monitor these patients with VMA, with homovanillic acid in the urine, and of course MHPG, which is seen in 97% of our patients. And urine catecholamine metabolite analysis is actually a very sensitive, not a very expensive, and a beautiful follow-up tumor marker for the children who are treated all over the world. Bone marrow examination, site-directed CECT, and of course MIBG scintigraphy is a part of diagnostic workup, and every student should know this. Again, don't look at the busy staging system, but just know that it is from the International Neuroblastoma Staging System, which looks at the extent of resection, extension across midline, involvement of nodes or distant tissue failures very specific to this kind of a tumor, which is skin, liver, and marrow. The principles of therapy depend upon age, localization, molecular features are diagnosis. Initial surgery is the approach followed closely by chemotherapy. There is very, very limited role of radiation therapy in neuroblastomas, although neuroblastomas are exquisitely radiosensitive, but our role is limited because most often failures are distant and most often children present with an advanced age. It is essential for our students to understand that retinoids are used, or vitamin A therapy is used as a method of differentiation, because you know these neuroblastomas, if they differentiate with the use of vitamin A into gangliogliomas, they become benign tumors. And this is such beautiful biology of something as simple as retinoid therapy. Coming to rhabdomyosarcomas, which is the next diagnosis, they are mostly sporadic. NRAS oncogene mutations are seen in about a third of the patients. And what we must know as the fundamentals of being students, the most commonest subtype is the embryonal subtype, often seen in orbit and head and neck sites. There are various cytogenetics that sign these tumors out. And again, like neuroblastomas, we see that hyperdiploidy. Here it is more than 53 chromosomes, which bring on a very favorable prognosis. And the reason here is if a tumor is hyperdiploid, which means that most often those nuclei would be in the G2M phase. And if that is the case, then chemo and radiation would be most beautifully acting on that part of the cell cycle. And that is why hyperdiploidy is an advantage. However, hyperdiploidy or polysomies are also a poor prognostic feature in brain tumors, and that I'm sure has been discussed in your previous teaching sessions. Clinical manifestations depend on the location of the rhabdo. Lab diagnoses are usually biopsies, bloods, urine, and marrow. Lumbar puncture when indicated. Radiological diagnosis, again, Shayan very beautifully said that even basic x-rays of those parts before you jump onto additional investigation bandwagons can provide a lot of information. Again, that's the International Rhabdomyosarcoma Staging System. I have put these busy slides for the sake of completion of a teaching seminar, but the principles behind these staging systems are captured on the text boxes. And again, the principles of staging systems are local extensions, post-surgical residual disease, and local or distant metastasis. So the treatment of rhabdomyosarcoma is actually dependent upon the site of the disease. Very high frequency of occult micrometastasis is seen, and all patients need chemotherapy. The initial surgery and biopsy is usually followed by first phase of chemotherapy for reduction of tumor burden, followed by radiation therapy. And the most active cytotoxic drugs here are vincristine, actinotoxo, ifos, ETO, and cisplatin. There is a current shortage of ifosfamide during this pandemic, and we are struggling because most of the ifosfamide comes from the Chinese manufacturers. So we are calculating equivalent doses of cyclophosphamide to ifosfamide, and this is something that you as JRs or SRs should know. Group 1, usually no radiation therapy unless we are looking at very highly selected cases. Group 2 to 4, radiation therapy after initial chemo, eventually after surgery, is essential. Here we must know that rhabdomyosarcomas need more dose compared to either Wilms or neuros because they are from muscular origin and muscle tissue is mostly resistant to effects of radiation therapy. I intentionally put in specific metastasis in rhabdomyosarcomas because as an evolving batch of trainees, one must get into the gamut of understanding how oligometastasis is now evolving into the domain of radiation oncologists with or without the combination of systemic agents. So rhabdomyos have a multidisciplinary approach based on location. For example, orbitals, parameningeal, female genitals, biliary tracts, etc. It is most often chemo and radiation because surgery is debilitating. For truncal tumors or tumors of the extremities, it is most often surgery followed by chemo and radiation therapy. Coming to retinoblastoma as my next list, they are malignant congenital tumors of the eye in children. Of course, median age of diagnosis is 2 years. They can be hereditary or acquired forms, bilateral involvement 20 to 30%, sporadic 60%, hereditary 40%. Here, as students, we must know the two-hit hypothesis of Knudsen. In the first step, the mutation of the germ cell, and in second step, you have the mutation of the retinal cell. These are autosomal dominant diseases with very high penetrance. And an alternation on the retinoblastoma loci that has been beautifully explained by Shayan in the first talk. Retinoblastomas, coming to pathology or clinical features, very common presentation is a cat's eye reflex that the mother comes and tells you that my child's eye appears white. And that is your first suspicion that you are handling a case of a retinoblastoma. Apart from that, you might have other signs and symptoms of disease. Coming to workup, it is most often a B mode, a clinical examination, of course, a B mode ultrasound, a CT of the globe, and often we do an MRI to rule out a trilateral retinoblastoma or involvement of CNS disease where CSI may have some role. Retinoblastoma is defined by the Rees-Ellsworth classification, and fundamental to that classification is whether the tumor is solitary or multiple, the relationship with the equator, and this is nothing but just to understand the visual prognosis of the disease based on the outcome or your approach to treatment, and of course size, which is classically measured as disc diameters because it can be easily seen on fundus examination. Survival of retinoblastomas is a lesson in humility. Survival has increased from 30% to currently 80 to 90% for all patients after risk-adapted therapy. With risk-adapted therapy, I mean, depending upon the stage, patients can be low risk and high risk, and often combination therapies have achieved this beautiful 80 to 90%. And our objective for retinoblastoma management is to maintain vision without endangering the life of the child. For very advanced unilateral disease, enucleate the eye followed by adjuvant therapy. For bilateral, enucleate the eye with very extensive tumor, but of course we must protect the other eye. You don't want a blind child. Radiation therapy has a niche role to play, often combined with chemotherapy and with surgery. These are highly radiosensitive tumors, and depending upon the age of the patient, the dose ranges between 35 to 40. Don't look at this range of 35. Most dose response studies have clearly proven data that anything 45 to 50.4 is the dose to go. In our hospital, we do 45 gray in 25 fractions, 1.8 gray per fraction, 5 days a week under anesthesia because these are often very young children. Laser photocoagulation for very small tumors and cryotherapy for small equatorial tumors. Coming to the last 3 slides of the presentation, I was supposed to discuss treatment-related sequel, and I thought what better than to put up a photograph. So on the left-hand side, you have cumulative incidence of chronic health condition of survivors, and you see that no survivor is free of disease. So every organ system has sequel of therapy, which again undermines the fact, which rather underscores the fact that follow-up is very essential for the children that you treat. And if you look at the cumulative incidence of severe disabling fatal conditions of survivors compared with siblings, the blue line is the survivor and the siblings are in yellow. And you see that for every disease that has been treated in childhood for a projected cure, if a cure has been achieved, then the cumulative incidence by the time the children have grown to adults at age 50 are considerably higher compared to their normal siblings. And that is sad, but it is a part of the story, and therefore follow-up and addressing these morbidities are important. I thought it is essential that I focus just on second primary cancers because as students and as practicing clinicians, this is something that we see now that the hospital is growing older. So 5-year survival rates approaching 85% for childhood cancers, as we learned. 50% of these survivors will develop a serious complication by age 50, we saw in the previous slide. Second primary cancers are the most devastating. Second primary cancers, what is the definition? So these are histologically distinct malignancies developing at least 2 months after the completion of treatment, although latency periods range shorter for chemotherapy induced, but much longer for radiation induced. And 30 years cumulative incidence from the children's oncology group cohort shows a 7.9% incidence at 30 years, and this is what the graph shows. If you look at the second malignant neoplasm line, it is about 7.9% at the end of 30 years, and that is considerable. They have unique associations. Chemotherapy causes myelodysplasia and acute myeloid leukemias of the T cell type, a short latency period, as I mentioned, often associated with alkylating agents or topoisomerase 2 inhibitors. Radiation-induced solid tumors, the latency exceeds 8 to 10, and radiation-induced solid primary cancers can be of various histological types, either within or just at the edge of the field. There is lower tumor induction with low LET radiation than high LET. And like Shayan said, it's important that you understand what LET means. And it is unclear whether it is the risk of tumor development is simply an absolute increase in proportion to dose, or is it because these children are actually predisposed to development of malignancies throughout their life? And therefore, follow-up is extremely essential. I think that I come to the end of my presentation so that I could meet within 40 minutes that was given to me. So to summarize, the healing process in children and adolescents with malignancies depends upon the knowledge and experience of those involved in the care for these children. It is usually a teamwork, and the overarching goal for every person involved is to deliver safe and evidence-based care for healing these children. Full information provision to and engagement of the family as a part of disease is very important. Adherence to protocols being used, and radiation doses, mind you, for pediatric and hematological malignancies are not what I decide as a radiation oncologist. It is a function of the protocol that the team is using. And we reiterate the importance of follow-up, as you saw in the previous 3 slides, because treating these children is only the first half of the stage show. So as follow-up increases, we are bound to face more morbidity. We have to be responsible for the morbidities that are a part of treatment and help improve quality of life for these survivors. It is important to identify and address relapse and treatment-related morbidity as elucidated too. Thank you. That was the last of my slides. And I thank each one of you for having spent the last 35 to 40 minutes with me at the end of a very busy working day. Thank you very much.
Thank you very much, madam, for such a wonderful presentation, and special thanks for your encouraging words. Hope it will inspire all the juniors.
Thank you, everybody. If there are questions, we are ready to take, or would everything be done on the chat box?
If anyone has any question, they can put it on the chat box.
So if there aren't any, we can see the reducing number of participants, but it's actually very encouraging to see more than, it was nearly 61, 62
More than
participants, and how it can get better, of course, but we should all, start enjoying the sessions that we have together.
Yes, ma'am.
Thank you. Then if there are no further questions, I would request and take permission to leave the session. And thank you, Shayan and Shondeep, for being such wonderful colleagues. Oh, yes.
How do retinoids convert neuroblastoma to ganglioglioma?
Oh, that is very interesting. Vitamin A, as a function of its chemical, aids in cell differentiation. So that is a part of human embryology. So the chemical of vitamin A, which is retinol, it helps in cell differentiation. So it is so simple. So such a simple concept that uses and neuroblastoma cells in the normal human embryological development. Neuroblastoma cell, or I won't say neuroblastoma, but neuroblasts differentiates into ganglion cells. And ganglion cells have no potential to divide. Okay.
Yes,
so I would rather say that it isn't ganglioglioma. I must have used the wrong term, but neuroblastic cells differentiate into mature ganglion cells. In brain, it would be ganglioglioma. So that was on my mind, but they just differentiate into ganglion cells. Okay.
Any more questions from anyone?
Okay,
no
I
more
think.
Questions. Okay.
Okay, chalo. Everybody have a good evening with your families, and
Thank
bye.
you, ma'am. Thank you again.
Chalo, bye.
Good night.
Thank you, everyone.
Thank you. Thank you so much.
So here we conclude our today.